The UroLift system is an ingenious but simple design. It allows for significant visual confirmation of opening of the prostate at the time of the procedure that results in dramatic improvement in patient symptoms. I think as development of this very well-tolerated procedure continues, we're going to find that it has a very important role in BPH therapy.
When the patient arrives at the clinic, approximately 30 minutes prior to being brought into the procedure room, he is given 10 milligrams of Valium. I always explain exactly what I'm going to do in terms of the passage of a small catheter and the installation of the liquid xylocaine and subsequent installation of the viscous xylocaine into the urethra.
Patients seem to tolerate this cystoscopy and the placement of the actual sutures. I think the key to that is the anesthesia and the dwell time of the anesthesia before we begin.
After he's been positioned on the procedure table, a small silastic catheter is passed into the bladder is emptied, and then a solution of 1% xylocaine liquid is instilled into the bladder. On withdrawal of the catheter, 10 cc's of viscous xylocaine, which is a 2% solution, is instilled into the urethra.
And we'll insert the scope now.
I think with appropriate anesthesia, lengthy dwell time of 15 to 20 minutes, and then gentle technique with some verbal anesthesia en route, I think patients tolerate this remarkably well. The actual device is inserted into the cystoscopy sheath in place of a long bridge that's used for the initial cystoscopy. So we do our cystoscopy, we leave the sheath in the bladder. Removing the long bridge will then appropriately prepare the device by removing the lock feature and insert it into the cystoscopy sheath. I tend to use my right hand for the patient's left side deployment, my left hand for the right side deployment. The device is really easy to maneuver. I just find that the deployment is not a problem. The squeezing of the handle is very simple, doesn't require much strength at all.
You see our little blue suture.
This procedure is easy to learn. The company has devised a model that gets us started, and then there's an impressive training program that follows. Individual case support is also going to be provided with proctoring as needed. I would propose that by 5 or 10 cases, the surgeon's going to feel very comfortable all by himself proceeding with future cases, and sometimes sooner, depending on the individual.
So that's much more open on the patient's left side. And we want to replicate that on this side.
You know, the problem I've encountered as a urologist is that although medications are effective, they're not without side effects, and the recurring monthly payments for co-payment purposes are onerous. I think patients would like a simpler and more definitive alternative. I think the UroLift system could be that alternative. We've had other minimally invasive procedures come along, and I've had experience with those. My impression of the UroLift system relative to the other minimally invasive procedures are that this system is better tolerated and allows for more rapid recovery with virtually no sexual side effects and significant improvement in BPH symptoms.
I don't know how to improve this, quite truthfully. I'm really pretty satisfied with it.
One of the really nice features of the UroLift system is its rapid recovery. Patients do have a little bit of hematuria, a little bit of discomfort with urination by the end of the first week, and sometimes sooner. We're getting verbal reports from patients that they are noticeably and significantly improved. And then we're collecting data at further points beyond that confirm that.
Thank you so much, and everything's good and happy, and we got her made.